Welcome to the ASCO eLearning Weekly Podcast, a weekly educational series focused on helping learners identify knowledge gaps and stay up to date with the latest in new drug developments, cancer treatments, and patient care approaches. Hello, my name is Helen Chew. I am Professor of Medicine and leader of the Clinical Breast Cancer Program at the University of California, Davis Comprehensive Cancer Center. Today we compared two patient cases on systemic therapy for metastatic triple-negative breast cancer. Triple-negative breast cancers are defined by their lack of estrogen or progesterone receptor staining and the absence of HER2 protein overexpression or gene amplification. Systemic therapy for metastatic triple-negative breast cancer remains a challenge. The mainstay of therapy is cytotoxic chemotherapy. In March 2019, based on the Impassion 130 trial, the anti-PD-L1 antibody atezolizumab was approved in combination with nab-paclitaxel in the first-line treatment of metastatic triple-negative breast cancer that expresses PD-L1. However, for triple-negative breast cancer without PD-L1 expression, immunotherapy is not an option. In addition, there are many indications for genetic counseling and testing, including patients diagnosed with breast cancer at age 45 years or younger, and patients with triple-negative breast cancer diagnosed at age 60 years or younger. Results of genetic testing may influence treatment options in metastatic breast cancer. Before we explore treatment options, let's look at two similar cases where treatment choices may differ. Can you identify the key differences? Let's begin with case 1, a 45-year-old woman with metastatic triple-negative breast cancer to the liver and lungs. 2 years earlier, she had received preoperative anthracycline and paclitaxel for a stage 2 triple-negative breast cancer. She had a limited family history of cancer and underwent genetic counseling and testing. No pathogenic mutations were found in a panel of genes associated with hereditary cancers. At the time of her metastatic recurrence, biopsy of a liver lesion confirmed metastatic carcinoma consistent with triple-negative breast cancer. There was no PD-L1 staining. The patient received carboplatin and gemcitabine for 6 cycles. She now has disease progression. Case 2 is a 57-year-old woman who also has metastatic triple-negative breast cancer involving the chest wall, liver, and bones. 3 years earlier, she had received adjuvant anthracycline and paclitaxel for a stage 2 triple-negative breast cancer. She had no family history of breast or ovarian cancer, but underwent genetic counseling and testing revealing a pathogenic germline BRCA1 mutation. At the time of metastatic recurrence, chest wall biopsy confirmed metastatic triple-negative breast cancer with no PD-L1 staining. The patient received carboplatin for 6 cycles with an initial response. 9 months later, she has disease progression. In each of these cases, what option would you recommend for subsequent systemic therapy? The choices include additional chemotherapy, such as capecitabine, eribulin, or vinorelbine, or a PARP inhibitor. In case 1, the correct answer is chemotherapy, including any of the named options. The patient does not harbor a germline BRCA mutation, so would not benefit from a PARP inhibitor. In case 2, the correct answer is a PARP inhibitor. In both the Olympiad and Embraca phase 3 trials, patients with germline BRCA mutations and previously treated HER2-negative metastatic breast cancer were randomized to either chemotherapy of physician's choice or to olaparib in the Olympiad trial or talazoparib in the Embraca trial. Approximately 40 to 50% of patients had triple-negative metastatic breast cancer in these two trials. Patients who received the PARP inhibitors had a significantly improved progression-free survival compared to chemotherapy in both trials. As a result, both PARP inhibitors, olaparib and talazoparib, are approved for patients with HER2-negative metastatic breast cancer who have germline BRCA mutations. These two cases of metastatic triple-negative breast cancer share similarities. Both cases met criteria for genetic counseling and testing, including the young age at diagnosis for case 1 and the diagnosis of triple-negative breast cancer at age 60 or younger in case 2. Both cases were treated similarly at initial presentation and on metastatic recurrence. However, the key difference is that no pathogenic mutation was detected in case 1. In contrast, a germline BRCA1 mutation was found in case 2. PARP inhibitors are associated with improved progression-free survival compared to the chemotherapy given in the Olympiad and Embraca trials in patients with germline BRCA mutations and HER2-negative, previously treated metastatic breast cancer. In addition, although both cases received a platinum-based regimen at metastatic recurrence, the TNT trial revealed that only patients with germline BRCA mutations and triple-negative metastatic breast cancer had improved progression-free survival with carboplatin compared to docetaxel. No difference in progression-free survival was seen in the trial population of triple-negative breast cancer without a germline mutation. Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. For more information on the treatment of metastatic breast cancer, including additional patient cases and opportunities for self-evaluation, visit the Comprehensive eLearning Center at elearning.asco.org. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org. The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.